Hi, today I want to talk to you a little bit about the various options that exist for management of your prostate cancer. If you're watching this video, nearly certainly we've gotten to a point where we're talking about active treatment for prostate cancer. Broadly speaking, there are three approaches. There is surgery, and that's typically a robotic assisted laparoscopic prostatectomy with lymph node removal, and that's done with the Da Vinci robot. There's radiation therapy with or without hormone manipulation therapy, which we'll spend a little bit more time talking about. Generally, surgery and radiation are going to be considered standard options. They've been evolving, but have been around for years and years. And we have long-term data in terms of how effective they are with respect to cancer control and what the side effect profile looks like, particularly with respect to impact on urinary function and erectile function. Over the last several years, there's been a lot of interest and awareness and research on ablative therapies. These are going to be treatments that don't target the whole prostate, but more commonly part of the prostate. Some of the more commonly available focal therapy options are cryotherapy of the prostate, HIFU, which stands for high intensity focused ultrasound of the prostate. There's also other options such as TULSA, ablation of the prostate tissue, irreversible electroporation, gold nanoparticles, and a variety of other options. I will say that these all remain somewhat investigational. They are not openly endorsed by any of the national major guidelines. Again, not because they're known to be inferior or ineffective. We just don't have the same quality of data to counsel you on their role. The first intervention I'll talk about is a robotic prostatectomy. So this operation entails putting in a camera, which is 8 millimeters, 3 robotic instruments that are also 8 millimeters, and an assist port, which is typically about 12 millimeters. We put the instruments in and we go in and separate the prostate from the bladder. We separate it from the rectum. We separate it from the urethra. And then we place it into a small bag called an endo-catch bag. We also remove all of the lymph nodes associated with the prostate and put those in a lymph bag and remove those. And then we sew the urethra and the bladder together. Walking through the entire process. So if you decide to receive a prostatectomy, you come into the hospital. The first thing we do is induce anesthesia, get a second IV. You're placed in a slightly head down position that helps the bowel contents fall out of the pelvis. We put in the instruments, and that whole process of inducing anesthesia, positioning, and putting in the instruments takes about 30 minutes. And then the operation commences. Generally, it takes about 2 to 3 hours, depending on the anatomy. Afterwards, you come to the recovery room and spend about an hour, hour and a half in the recovery room. If it's the first case of the day, most of the time, we'll try to get you home later that evening. If it's the second case, we'll typically keep an eye on you overnight. The surgery itself is one of the more common urologic oncology procedures that we perform. There are risks, just like with any operation of bleeding or infection. Cumulatively, that's about 1 in 100 patients, not very common. We do always ask for permission to give you a blood transfusion. Certainly, if you have religious or otherwise objections to blood transfusion, we want to work with you. The other structures that can potentially get involved and injured are the rectum, the ureters, which are the tubes that go down from the kidney to the bladder, and the urethra. Again, outside of special circumstances like post-radiation or extensive abdominal surgery, those are also quite rare. So the operation itself is fairly straightforward, I would say, for most urologic oncologists. But when it comes to management of prostate cancer and prostate cancer surgery, there's really 3 outcomes of interest that are really central to the whole conversation. The first is cancer control. And the likelihood of surgery alone being curative does matter on a variety of factors. It is impacted by your diagnostic PSA. It's impacted by your Gleason score or prostate cancer grade group. It's impacted by the clinical exam, whether or not a mass was palpable and how big or advanced that mass would be, whether or not there was any concern for lymph node involvement, and then also how many biopsy cores were involved with cancer. So it's variable, but suffice it to say, if you have localized prostate cancer, the likelihood of cure for very low, relatively low risk cancer is extremely high, with cure rates approaching about 90%. For more aggressive cancers, such as grade group 5 cancers, very high PSA, we do see a drop off in cure rates that are closer to about 40 to 50%. So the first thing is cancer control, and certainly we'll spend some time talking about your specifics based on your age, your PSA, your Gleason score, your clinical exam. The second is urinary continence. So when we separate the prostate from the bladder and from the urethra, there is typically going to be, so just to kind of play things out a bit further, when the operation's done, we put a catheter in between the urethra and the bladder, and that's put in place for approximately 1 week. It's fairly easy to take care of, and we show you how to do that before you leave the hospital. When the catheter comes out, it's normal, it's expected, it's a part of the process to have some leakage of urine. On one end of the spectrum, people hardly leak at all. But importantly, on the other end of the spectrum, some people can have complete and total incontinence, where as soon as urine enters their bladder, it immediately leaks out. So early on, pads are typically used, and pads can be variable depending on the type. They can be adult diapers, like it depends. They can be thin pads or thick pads or guards that go into the undergarment. The pad usage can range. It ranges on the absolute amount of urine that's leaked. It ranges on the type of pads that are used. It ranges on how frequently those pads are changed. And it can be as low as, hardly any at all, or it can be as high as 6 to 8 full diapers per day with guards in between. So first off, we would have you start doing Kegel exercises. These are exercises to actually start strengthening the urinary sphincter even before the operation. And probably the easiest way to kind of think about it is if you think about your anus as kind of like a camera aperture, we want you to actually consider like you're closing that aperture. So you want to close it, hold for a second, release. Close it, hold for a second, release. Do that 10 times and do about 3 sets of 10 leading up to the operation. Those same muscles groups are involved in urinary continence, and that nearly certainly will be helpful. So typically, once the catheter comes out, we'll have you start doing Kegel exercises. And generally, we see a fairly marked improvement in continence recovery within the initial 8 to 12 weeks after surgery. By about 12 weeks, about 80% of men are using 2 pads or less per day. And at that point, depending on the degree of leakage and the degree of bother, we can certainly have a conversation about whether or not you would benefit from seeing a physical therapist. They're tremendous. They're miracle workers. They'll teach you to confirm that you're doing the Kegel exercises correctly, and they can even teach you additional maneuvers to help out with continence recovery. By 6 months, about 95% of men are dry, or they leave 1 pad in as an insurance policy. If at that point you have persistent leakage, again, depending on the degree and the bother, we do have second procedures such as urinary slings and urinary sphincters, which can get you dry. And that is typically done in conjunction with our reconstructive urologist. So the take-home messages are that leakage after surgery is normal. It gets better, but it can take some time to get better. This is important to understand. I would feel fairly comfortable going off the record and saying that generally these days, with delicate tissue handling, with high volume of cases, and with the visualization that the robot allows us, that typically leakage is not much of an issue. So we've talked a little bit about cancer control, and that's going to be depending on your preoperative factors. We've talked a little bit about urinary leakage. And the final component is impact on erectile function. So the biggest predictor of post-operative erectile function is actually pre-operative erectile function. So if you're having good, firm erections without any issues or problems sufficient for intercourse, that's going to be a major positive factor in your basket. The other, of course, is the degree of cancer. If there's any evidence that the cancer is extending into the lymph nodes, of course, they have a very low threshold to move those. So the way this works is actually there's neurovascular bundles, a right-sided one and a left-sided one, that are literally enveloping and cradling the prostate, and they go from the pelvic nerves towards the prostate, are involved in the ability to obtain and maintain erections. So nerve sparing, I kind of liken that to peeling a label off a jar. Sometimes it comes off easily, completely intact, and it's very simple and satisfying. Sometimes you have to work on it, and it's tough, and it rips and it tears, and you have to begin at every corner, and it can be quite challenging. But across all comers, this is going to be people with good erectile function, intermediate and poor erectile function. If we're able to do a bilateral nerve sparing, the likelihood of having erections sufficient for intercourse, oftentimes with the help of medications like Viagra and Cialis, are going to be in about the 40% range. If it's one-sided, it typically drops off closer to about 20%. And if no nerve sparing is performed, either because of cancer characteristics or because of a complete lack of erectile function going into it, it would not be expected that your erectile function would get better after surgery. So so these are long structures from the brain through the spinal cord ultimately to the penis that allow us to obtain and maintain erections. They take a while to rejuvenate and rehabilitate. After surgery, we'll typically start you out on Cialis 5 milligrams daily. And that just kind of helps out with blood flow and health of the erectile tissue. Once restrictions are lifted in terms of activities, which is typically about 3 weeks, you're certainly welcome to try taking up to 20 milligrams daily prior to some type of stimulatory activity. Then again, just kind of depending on how you're doing and how it's prioritized, we can ramp things up. Those include vacuum erection devices, which mechanically draw blood into the penis with constrictive rings. Injection therapy, which are vasoactive substances that bring blood into the penis. There's urethral suppositories. Those are largely falling out of favor these days, to be quite candid. And then finally, we do have surgical corrections with multi-component and malleable penile prostheses that are done in conjunction with our men's health colleagues. So erectile function is much harder to provide reliable patient-level preoperative data on. If you've got good erections and nerve sparing can be performed, I think it's fine to be cautiously optimistic. If you don't, there's a real chance that the erection may take a hit. There are some there's features of surgery that may be attractive to patients. So after surgery, the PSA should go to 0 and stay 0. It becomes binary. Once the prostate and the lymph nodes are removed, that all goes to a pathologist. They look at everything under the microscope and then give us a final assessment of the stage, grade, extent of cancer, and margin status. And then if you were to have a recurrence of cancer after surgery, typically layering on second interventions like radiation is fairly straightforward. So that's just kind of a broad overview into surgery. Of course, the downsides of surgery is that it is a procedure. It's a procedure requiring general anesthesia, and general anesthesia is generally safe, but there's always those small risks. Anytime we do surgery, talk a little bit about the complications. If you've had previous abdominal surgery that's extensive, sometimes there's additional risks that can come into play in terms of safely accessing the abdomen. And then the impact on erectile function and urinary function that we talked about. So the next option is radiation. So radiation comes in a variety of approaches, and There are relative and contra indications to certain types of radiation, which we'll cover kind of at a case-specific basis. So the first thing that I think is worth mentioning is, depending on your cancer characteristics, if you're considered unfavorable or intermediate risk, typically we like to give androgen deprivation therapy before and during and after radiation. And the way you can think about it simply is prostate cancer is fire, testosterone is a fuel source. So you want to give you medications to cause the testosterone levels to go down. That kind of stuns the prostate cancer cells and makes them susceptible to the radiation. Those medications, we typically give them along with vitamin D and calcium because they can impact bone health. We get a baseline bone health scan, and they do have a host of side effects due to the removal of androgens, including hot flashes, breast development, loss of muscle mass, increase in fat mass, and some potential increase in cardiovascular risk disease. It is an important part of radiation for unfavorable intermediate prostate cancer. Then the radiation itself is administered by a radiation oncologist, and they would talk to you about the different options. There's external beam radiation, there's seed radiation, there's typical long course radiation, there's short course radiation, and then there's proton therapy. So there's a lot of different ways that radiation can be delivered. Sometimes we put in a little gel to separate the rectum and the prostate to help out with some of the side effects. But a standard kind of radiation program would be with or without the androgen deprivation therapy. You meet with radiation oncologists, they get images of the pelvis, typically CT scans or MRIs, and that's called a simulation or planning. And then you generally come in about anywhere from about 25 up till about 40 days. So about 5 to 8 weeks. Sometimes, again, it can be longer. Sometimes it can be shorter. And you come in every day for about an hour and a half or so. You receive your radiation dose, and then you can go about your business. The short and intermediate term side effects are going to be urinary frequency and urgency, bowel frequency and urgency, and then rectal frequency and urgency. Those are some things that we kind of commonly see with radiation. Sometimes we see fatigue as well. Many times those are self-limited, transient, and either just resolve on themselves, or we can give you medication to help out with urinating. In a small fraction of patients, they do persist. Long-term, sometimes you can develop something called radiation cystitis, which is where the bladder gets irritated. And you have issues and problems with persistent bleeding. Same thing with proctitis, where a similar type of phenomenon happens with the rectum. Fortunately, dangerous things where the radiation kind of causes injuries to the rectum, which can lead to communications with the urinary system, are exceedingly rare. Over time, we do see drop-offs in erectile function, urinary function, and bladder function over time. And in a small fraction of men, actually secondary cancers can form from the radiation. The obvious benefit of radiation is you don't have to undergo a surgery. The downsides can be urinary frequency and urgency, rectal frequency and urgency, and a longer term impact on erectile function. If your cancer were to recur, it's harder to treat after radiation. Our options are a bit more limited. And after radiation, it's not typical for the PSA to go down to 0 just because the prostate's still in place. Finally, that brings us to ablation. So ablation is where we use a variety of different energies. Again, that could be ultrasound, it could be freezing, it could be electricity, it could be lasers to, instead of treat the whole prostate, to treat part of the prostate. Most of these are done under general anesthesia. Most of them are day surgery procedures. The pros are that the impact on sexual and urinary function is typically better than either radiation or surgery. The downside is that you are at risk of having cancer return in other parts of the prostate, and we just don't have the same long-term follow-up data. The most important thing to note with ablation therapies is that they're not standard of care, and we really need to have highly select patients. We don't want to have people that have big, large, aggressive tumors, you're not going to be a good candidate at all whatsoever. So the important thing about ablation is to really assess candidacy depending on what your MRI looks like, where the biopsies are positive, and what the stage and grade of the tumors are. The important last thing I want to leave you with is you're going to be fine. We've got great options to get you through this. With localized prostate cancer, the likelihood of you being alive at about 10 to 15 years with good treatment approaches about 99%. We're happy to guide you through that journey with our expert team. Thank you so much for your attention today.